Sucks being. Okay. First of all, respiratory failure is not a primary condition. It's a result of something else. Okay, like heart failure, meaning what were the causes of heart failure again? Valve problems, right? Arrhythmias, a heart attack can cause heart failure. So same concept here. So when you say patient is in respiratory failure, that's not the primary diagnosis because the treatment for respiratory failure, just respiratory failure, is oxygen. But of course, something led to it, correct? So that means you have to treat the underlying cause. So the patient will never come into the hospital, oh, main diagnosis is respiratory failure. No, it's either pneumonia with respiratory failure, but you'll see when we look at the risk factors or the causes, it's not mainly respiratory or pulmonary problems. There are non-pulmonary causes that lead to respiratory failure. Sepsis is one of them. Okay. So what is this condition? It's a sudden life-threatening deterioration. Now you meet respiratory failure diagnosis when you have these three appearing on your ABG. So we need an ABG in order to diagnose respiratory failure. First is your PaO2 is less than 60. Number two, your CO2, PaCO2 is over 50. And the patient's pH is less than 7.35. Those are the three. So regardless of the underlying condition, if your ABG shows the following, a PaO2 of less than 60, a PaCO2 over 50, and your oxygen, your pH is less than 7.35, then you are in respiratory failure. Now, of course, if your pH is less than 735, PaCO2 over 50, PaO2 less than 60, your oxygen saturation must be below 90, correct? So you add that as well, right? So that's the fourth requirement. Oxygen saturation less than 90. Now, this chapter will only focus on acute respiratory failure. Chronic respiratory failure is not life-threatening. That's chronic. That's just treated with oxygen. However, for acute respiratory failure, yes, we give them oxygen, and if needed, we insert an airway and put them on a ventilator. However, the treatment is focused on the underlying condition, okay? Because otherwise, you'll be on oxygen forever and never leave the hospital. Okay? That is if you survive. Okay. There are two types of respiratory failure. There is a hypoxemic and hypercapnic. It's pretty easy. So if it's hypoxemic, then that means your oxygen is low. And if it's hypercapnic, your CO2 is high. But usually in both cases, they are both high. Oh no, sorry. They are both, PaO2 is low and then CO2 is high. So both are present. But not all the time though. Some patients purely have the hypoxemic. Then some patients have purely hypercapnic respiratory failure. Examples of mixed are those with pneumonia, COPD, and you can throw in asthma and COVID there as well. Okay, so they have mixed hypercapnic and hypoxemic at the same time. These are the causes. So non-pulmonary causes are the following. Drug overdose. What happens to right. Let me just explain so it's easier for you to understand. When we say hypoxemic, meaning oxygen is low, correct? So that means there must be something that impaired gas exchange. The underlying cause has the nature of impairing gas exchange, however that is accomplished. So let's say that could be including pneumonia or COPD, or let's say COVID, which leads to pneumonia, asthma, or let's say drowning, for instance. Okay, so you drown, so that anything of those impairs gas exchange, correct? Okay. Or let's say you aspirated. Okay, so you have tacos in your in your airway and then reach the lungs. Okay, so you have your burritos in there. So that is hypoxemic. Now, when we say hypercapnic, these are conditions that affect the rate and depth of your ventilation. So we call that ventilatory or hypercapnic respiratory failure. So any condition that results in shallow breathing as well as low respiratory rate, which is present in drug overdose, correct? Let's say you OD. So what happens to you? How did we know you OD? What's your respiratory rate? Less than 10, right? So that's what causes hypercapnic. So same thing also head trauma. So head trauma, and then you have brain herniation. So what's the first thing affected next to level of consciousness? Respirations also drop, okay? So same infection, which is sepsis, right? Respiratory rate drops, right? And hemorrhage, same thing. It impairs, and then sleep apnea also. Or here, myasthenia gravis, it affects the diaphragm, right? Guillain-Barré, ALS, spinal cord trauma, or let's say obesity, massive obesity, or chest trauma, kyphoscoliosis. Look at this. You have kypho and scoliosis, so that will, of course, affect the depth of your respiration, malnutrition. Okay, or let's say it can also be mechanical. So let's say you're into, your partner is 600 pounds. And then you experimented on, okay, you be on top, right? So can that lead to respiratory failure? Yes. Okay. All right. So that would fall under chest trauma, I guess. Yeah.
Oh, God.
Okay.
Trauma.
So any questions on oxygenation or hypoxemic and hypercapnic respiratory failure? Okay, so you can see here clearly it's not always pulmonary. Okay, so it can be non-pulmonary as well. In the case of burns, I would say that would be under hypoxemic. Yeah, because that leads to ARDS, meaning gas exchange is impaired because your lungs are wet. Right. So manifestations, nothing really exclusive to respiratory failure. I mean, it's the same as anybody who is in respiratory distress, which are restlessness, fatigue, headache, okay, air hunger, increased BP. Okay, so this is present in COPD, pneumonia, right? I mean, nothing exclusively seen in respiratory failure. But what are those three ABG findings again? PaO2 less than 60, PaCO2 over 50, pH less than 735.
Oxygen less than.
Yeah, and then the oxygen saturation less than 90. For management, again, the focus here, if you're just talking about respiratory itself, the only treatment is oxygen. Okay, you give oxygen, you titrate. Okay, so we can't meet it with a nasal cannula, you go with a mask. Simple mask can't make it, okay, you go to non-rebreather. You can't do a non-rebreather, okay, let's put this patient on a BiPAP. BiPAP doesn't cut it, let's intubate the patient. All right? Right, so the treatment for respiratory itself is just the oxygen, okay? Oxygen therapy, that's it. But the objective, of course, is to correct the underlying cause. All right? Of course, which one will be easier to treat, the underlying cause or the oxygen first? Okay, oxygen is priority. Okay, we'll take care of the underlying cause right after we provide oxygen. Okay. No, it's because this patient won't survive. So let's take one of these, for instance. So let's choose drug overdose. Okay, so let's say you gave Narcan, right? And then you reversed it. So which one will you prioritize? The oxygen, giving oxygen, or giving the Narcan?
You get the Narcan already, you said?
No, which one will you give first? Of course, oxygen first. Right. So that's what we mean by, of course, because it's ABC. So you have to prioritize the oxygen. Because not all of these are easy to fix. Let's say if it's sepsis from infection, is it easy to treat sepsis? No, right? It'll take a week, right? Or at least a few days to treat sepsis. Until then, right? Or if needed, since it'll be a while, the patient will have to be intubated. Okay, which brings us to our next step. Not yet. Let's go ARDS first. And we'll come back to airway management. ARDS. This is still respiratory failure. This is a progressive type though. So since this is respiratory failure, what will the ABG show?
Can show
PaO2 less than 60, PaCO2 over 50, pH less than 7.35, and oxygen saturation below 90. Okay, all of those are there. However, unlike respiratory failure, which responds and improves with oxygen, ARDS is refractory to oxygen, meaning the hypoxemia here persists. Even if you give the patient gallons of oxygen, they will not improve. They stay hypoxemic, they stay hypercapnic. Okay, so now it's diagnosed as ARDS. So how do we make a diagnosis? Let's take first the pathophysiology. So what happens actually here? You remember the capillary leak syndrome in sepsis? That's exactly what happened here. So the patient, let's look at the underlying causes. So the direct cause of ARDS is acute lung injury. Now there are two types of acute lung injury. It can be direct acute lung injury or indirect acute lung injury. Okay, so either direct or indirect ALI. These are examples. So if it's direct injury, we're talking about aspiration or smoke inhalation, okay, or burns through the airway. That's direct lung injury, right? You injure the lung tissue itself. Indirectly are all forms of shock. Those are the most common. So this will include conditions that precipitates sepsis, for instance. So let's say pancreatitis, peritonitis, those conditions, right? Because they start local and then they become systemic. The patient goes into septic shock and then they result in indirect lung injury. Okay. So when you say indirect lung injury though, don't take it literally that, oh, the pancreatitis, the infection went to the lung. No, it did not. It just means that the effects became systemic. Okay, so let's say in sepsis, for instance, sepsis, is it still localized? No, it's a whole body response right now. So every single capillary in the body became leaky, right? They became very vascular, very permeable, sorry. So the increased capillary membrane permeability here leads to the indirect lung injury. Okay, so we say lung injury because the lungs are containing millions of capillaries. Imagine we have 100 million alveoli, each wrapped with a capillary network. So you can't describe any other organ that has so much capillaries, so much vascular perfusion as the lungs. So we call it acute lung injury. Okay. This one, look at the mortality, 27 to 50%. What is the publishing date for this textbook? 2018, something like that, or 2020? Okay, so let's say 2020. This is 2020. The mortality from the 1950s, which is what, 50, 70 years ago, was still the same. It was still 27 to 50%. How come we did not? I mean, compare 1950 to now. Is the treatment comparable? No, night and day, right? We had so much, we have so much treatment modalities now. In the 1950s, nothing. Okay, we had nothing. We still had negative pressure ventilators. Okay, we didn't have positive pressure ventilators until now. I mean, unlike today. But the mortality did not change. So what can you say about ARDS? It's very deadly. You can't beat this thing. Okay. So you go into ARDS, 50%. So for 50% chance, yeah, you may live, you may die. All right, that's it. That's the best we could do. Okay, so there's no, there's no treatment until today to date that has beaten ARDS. Okay, ARDS 1,
Humans.
humans 1. Okay, so the score is still tied. It's still 50-50. Here are your risk factors. So as I said, just like respiratory failure, is it always pulmonary? No, there are non-pulmonary conditions here as well. So aspiration, as already described, COVID pneumonia, drug overdose, embolism, these actually DIC is not really
Would be like
a
result of-
cause, yeah, because this one DIC occurs at exactly the same time as ARDS because the triggers are the same, right? So the nature of DIC is also, what were the causes of DIC? Trauma, cancer, shock. Okay, so they had the same risk factors. So once those people, same people develop ARDS, most likely they're developing DIC at the same time. So they're not dealing with just ARDS. They're dealing with DIC at the same time, plus the underlying causes that led to DIC and ARDS. So that doesn't help really with the mortality, does it? Okay. Infection, which leads to pneumonia, or including COVID pneumonia, major surgery, because that falls under trauma. Metabolic disorders, I mentioned pancreatitis, uremia, because those lead to sepsis. And then inhalation, you can include burns there, sepsis and shock and trauma. Right, so these are the conditions. So they're not, mild conditions. Okay, these are serious underlying conditions that, of course, lead to ARDS. And always think that the IC is occurring at the same time as well. So I won't repeat. The problem again is the increased capillary membrane permeability as the human body is exposed to these serious injuries that lead to direct or indirect acute lung injury. So the capillaries become leaky. And in the case of the lungs, of course, there's only one place the fluid will leak into, right? It's the alveoli. So that's why, what happens to gas exchange now? If the lungs are wet, can gas exchange occur? No, the lungs have to be dry for gases to exchange. It can't exchange. Can you fart into water? No, you can fart when you're in the water, but if you're above the pool, you cannot fart into the water, so gas exchange is impossible. So the only way to perfuse this patient's lungs is through mechanical ventilation. You have to force the breath into the patient's alveoli. Okay, so lung compliance refers to the, if you don't understand lung compliance, it's the pliability, okay, the softness of the lung. So the lung is naturally dry, correct? So if it's dry, it's very compliant, meaning it will expand, it will contract, okay, fill with air, push out air. But if it's wet, is it still the same? No. Like if it's a wet sponge already, can it absorb anymore? No. So gas exchange is impossible. So you have to dry it. So that's what compliance means. Lung compliance, the condition's the same. If you have pulmonary edema caused by, let's say, heart failure, or pulmonary edema from a PE, for instance, the same. Lung compliance will drop, okay? All right, manifestations, of course, same as respiratory failure because this is respiratory failure, okay? However, a few things will show up on the diagnostics. Number one, when you give oxygen, will the patient improve? No. So that tells us compliance is low and the lungs are wet. Okay, so we can't. So the symptoms stay the same, ABG stays the same, oxygen saturation stays low. So when we take an X-ray, the patient will of course have wet lungs. So the lungs will appear wet. The description there is a white out experience. White out appearance, sorry. or it's also called ground glass appearance. Have you ever ground glass? So when you pulverize glass, no matter if it's clear glass, white glass, green glass, red glass, brown glass, when you grind it, what does it look like? It becomes white, okay? So that's what the patient's x-ray will show. Because normally, what do lungs look like on x-ray? Black. But now, why are they white?
Water.
Filled with water, all wet. So they're decreased pulmonary compliance. So they're very stiff, okay, very hard to ventilate. So we need a ventilator, mechanical ventilator. Okay, so these are the other manifestations, intercostal retractions, and I already mentioned about ground glass appearance, yeah? And then refractory hypoxemia, meaning no matter how much oxygen you give, they do not improve, stay hypoxemic. All right, so we also draw BNP because remember there's pulmonary edema here. Yeah. So, and as described here, it says findings on X-ray are similar to those of cardiogenic pulmonary edema, meaning the same as if this patient was in heart failure. So same type of edema. However, in order to distinguish, because the manifestations are the same, how do we know that this pulmonary edema is cardiogenic or ARDS? So the answer is in BNP. So when you draw BNP, what do you think will show?
It's gonna be normal.
The BNP is going to be normal or sometimes it may be low. Okay, so normal or low BNP. So that tells you, is this a heart failure pulmonary edema? No, this is ARDS. And you look at the patients are the symptoms. And of course, you investigate what led to this whole thing. So you see, there's pneumonia, or let's say this is sepsis from a UTI or this wound, for instance, okay, or whatever. Okay, so those are the diagnostic tests that help us distinguish. Okay, because we need to know. Because if let's say we misdiagnose this, this is heart failure, and then we start giving diuretics, what will happen to this patient? Right, because remember, there's congestion here in the lungs. However, it's not a cardiac problem, right? It's the capillary membrane permeability that's causing this edema. Management, as in respiratory failure, what is the focus again? Treat the underlying cause. Okay, but until then, what's your priority? Oxygen. Okay, so we give oxygen, aggressive oxygenation support. Most likely, these patients will be intubated. So as soon as we see the whiteout appearance, patient will be intubated if they're not intubated already and placed on a mechanical ventilator. All right, so let's look at the airway management now. I'll come back to this section later. No, let's finish the drug therapy because there are drug therapies here. So first statement here says no specific drug treatment for ARDS except supportive care. So the focus for drug treatment will be on the underlying cause instead. So if it's sepsis leading to this, then we give antibiotics appropriate to the organism grown. Okay, and these drugs here, the neuromuscular blocking agents, sedatives, analgesics, are really because the patient is already on a ventilator. Okay, so to keep them comfortable, we give these drugs continuously. Okay, keep them comfortable so they're not spending so much energy because it's not fun having a machine breathe for you. Okay, it's not fun. So you'll be anxious, you'll be fighting with the ventilator because the ventilator is giving you breaths. Okay, you're not. Are we supposed to have a machine breathing for us? No, we're supposed to breathe whenever we want. So freedom is affected here. So you have no control over your own ventilation, your own breathing. So we have to keep you relaxed. Okay, so you don't fight. We give you these drugs, we sedate you, chill out. Okay, we got you. So the patient's not expending so much energy because they don't have any energy. Okay, this is oxygenation problem. So no oxygen, no ATP, patient's very weak. Nutritional therapy, this will be, of course, the patient will, because this is short term, the patient will receive an NG feeding tube. And put given whatever feeding is appropriate. And because they are intubated, so initially they will be in the ICU. That's it. Let's take a break. Come back at 2:45 eventually.